This conference will now be recorded.
Okay, so we'll talk today about the types of studies. This is a flow chart of just describing the types of studies that you might know and the type of the known studies, basically. I will start from the last row, basically. I will not start from above here, okay, because this is just description of these studies. I'll start with this case report. Does anybody know what is case report and what entail? What is the case report involve?
Yes, case report does a detailed history about a particular condition or a particular disease.
Yeah. So it is something like you find a rare case in surgery, for example, a rare kind of hernia, in gynecology, a rare kind of pathology you found, and you decided to share this case with your colleagues. So you start to write this case in details, how this case presented, how you manage this case, what is the outcome, and these things. So it's just a description of one case, okay? And the second type of studies or papers or whatever, we call it case series. It's just very similar actually, but just multiple cases. This is not just one case. As we found, for example, a pathology. For example, in surgery, have rare pathology like esophageal injuries or something like this, and gynae, I believe they will have very similar. And you decide, you've seen several cases, and you decided to describe these cases and put them in a paper and describe the management and the presentation and everything about these cases. So in these type of studies, you're just describing things. So we call it descriptive studies. And as a level of evidence, is not the strongest evidence to prove something, okay? But it's still, do you think it's an important studies? What do you think? Do you have any ideas? Are these papers or studies are important? Anybody have any?
They're also important, but it's not a high level of evidence.
Yeah, but they are still important, aren't they?
Yeah, they are.
Yes, they are really important. So something like HIV is being discovered by case reports. Actually, several case reports came describing certain pathology, and after somebody went through these cases, they discovered that there is a new disease, which is the HIV, which is something very, very well known today. So they are important, but they're not the strongest evidence. Okay, we'll move to the next type of study, which is cross-sectional study. Does anybody know what is cross-sectional study?
Yes, this study for prevalence.
Yes, exactly. That's a key word actually. The word prevalence of something is a key word for cross-sectional study. So it's basically I decided to go to a certain population in a point of time and study something or pathology in this population. Okay, so it's at a point of time now. I'm studying now at this certain point of time the prevalence of cervical cancer, for example, in the population of Manchester, for example. Okay, so that's a cross-sectional study. Okay, so the key words in this type of study is prevalence, because I'm studying prevalence of something, and a point of time. So these are two key points in these studies. Okay, moving to the next one, case control study. Does anybody know what is case control study? Or why we need to do case
Studying a
control?
case.
I'm sorry?
Yes, studying a case. Studying a case or a particular case. Two groups.
Okay.
Disease group and the control group.
Okay, fine. So yes, exactly. But let me ask you as well, do you know what is cohort study?
This a long study, long time, or some cases in the
study with the disease and without the disease.
Yeah, so there are basically maybe two groups as well, but you know, these two types of studies, case control and cohort studies, might be directed to very similar things. I'll give you an example. Something like cervical cancer is relatively common. Okay, so you can decide if you want to study what is the causes of cervical cancer. You can decide that I will go to the people of Liverpool, for example, and follow them throughout the time and see how many women and these people developed cervical cancer. Okay, and during this period of time, I am monitoring and documenting and writing all the factors these people subjected to. And by the end of this study, I'll find some people got a cervical cancer and some people didn't get a cervical cancer. Okay, so I followed a cohort of people, okay, in time. Okay, so it's something like a prospective study. Is study done usually in the future. So I studied this. Do you know what cohort mean? The word cohort.
A selected group of people.
Yeah, it's a group of something. It's yeah, it's a group of individuals. It's even like a herd of sheep, like a cohort of you. It's a group of people. It's just directed to a group of people, and following them with time, and to see what's happening to these people, and which group of them developed certain pathology, and which group didn't develop this pathology, and study why these people developed this pathology and why these people didn't develop this pathology, and just compare these two groups. So I've not started this study with two groups. I've just ended this study with two groups by the end of the study. Okay, and then I can compare between these two groups. So can anybody tell me any rare gynecological problem or obstetric pathology example of any something rare?
Acute fatty liver in pregnancy.
Yeah, that's thing. Okay, fine. So, for example, if I decided to study this pathology in Liverpool people, do you think how many of the women of Liverpool will develop this pathology in a year time? So that's a rare condition, isn't it?
Yeah.
Okay.
Won't be a lot.
So it will be something like 3, 4. Okay,
Yeah.
and for example, this town or this city has something like 1 billion population. So do you think I can do a study, like a cohort study, to study this pathology?
No.
No.
It have to be
Okay.
retrospective.
Yeah, it has to be something like retrospective. I agree with you. There's another way of doing that. Okay, is to select a group of people that have already this pathology. Okay, for example, in Liverpool and Manchester and Leicester and whatever, these, you know, northwest of England, for example, I have about 50 women have this pathology, and decide to bring another 50 women without this pathology. Okay, and start asking both groups what happened in the last 5 years, and what happened to you that might caused this pathology. So I have a group of people with a pathology and a group of people without a pathology. The other group, the normal group, we call it control group, and that's exactly the case control study. That's what we call the case control study. And that's the difference between the case control study and the cohort study. It's just studying things difference between two groups and study why this pathology has developed and why this pathology hasn't. But I can do cohort study in relatively common diseases, but I can't do it in rare diseases. So I have to do what we call a case control study. Do you understand this point?
Yes.
Okay.
Yes.
And yeah, and the other thing is usually cohort study is prospective. You do it in the future, and the case control study is retrospective. You bring these people and these people, and you start asking them what happened in the past. Okay. So in essence, the cohort study are more accurate because you are controlling everything with time. You started monitoring everything since you started your study, but the case control study is not that accurate because it happened in the past. You ask about them, about things in the past. Some sort of bias happen here. It's called retention bias. This viewer might not remember things accurately and things like this. Okay, so these three studies, the cross-sectional and case control and cohort studies, we call them analytical studies. There's some sort of statistical analysis happening in these studies. It's not something like descriptive, like the case report and the case series, okay? But both categories are observational. So just observe stuff. You don't do anything yourself, okay? But there are other studies. You do something. You experiment, okay? And these are, you have the it's not the ultimate control, but the maximum control of the things because you are putting the change yourself. You're giving treatment. You are usually giving treatment actually. So you are selecting two groups and you decide to give treatment to some people, to give placebo or another treatment to some people, and just compare the outcome. And these are the RCTs. Do you know what is RCTs?
Randomized control trials?
Yes, it's randomized control trial. So it's a control trial. Okay. We mean by control trial, it's there is a control group. Okay, there is an experimental group and there is a control group, and it's randomized. So from the start, they have to randomize people to to the experimental group or to the control group. Okay, and there are non-RCTs. So some studies, I'm just experimenting in a group of people and there is no control group. Okay, so for example, when I'm inventing a new drug or something like this, in the early phases of testing the drugs, I have to choose some volunteers and test this drug on them. Okay, to check if it is safe or something like this. So there is no control group. So that's not a randomized control trials, or that's not a control trial. That's what we call it will happen here as a quasi experiment or something like this. Okay, so let's go through what the wrote here about these studies, just as a quick revision about what we said. They spoke here about meta-analysis and systematic reviews, and we haven't spoke about this yet. Do you know what is systematic review?
Excuse me, Dr. Muhammad.
Yeah.
I'm not started from beginning. I'm started from cohort, okay? You can.
This conference will now be recorded.
Okay, so does anybody know what is systematic review?
Systematic review look like a summary of literatures, clinical literatures, in which you summarize different studies.
Yeah.
Then put them together.
Yeah, that's all right. That's right. Yeah. So what is meta-analysis?
The same but different.
Mm-hmm. Again,
Yeah.
I'm sorry?
You are pulling results of different studies together using a statistical methods.
Yes, exactly. So let me speak about systematic review. So let's say you are trying to answer some sort of question. So for example, is chemotherapy versus surgery in treating some sort of cancer, okay, or certain type of combination of treatment, neoadjuvant and then surgery and then adjuvant chemotherapy versus just surgery alone versus whatever in certain type of cancer. So you've been to search the literature and you find a lot of studies, but there are some different answers and different recommendations from different studies. So what you want to do, if you are going to do a systematic review, you will decide to have a clear question, what we call a BICO question, with a well-known pathology, P, or population, and I, which is the intervention, to decide what intervention you want to ask about, and C is the comparison between this intervention and the control group or another intervention, and O is outcome, and what are these outcome, and start to search the literature systematically with a well-known and designed question, and you find a lot of studies, and you will go through all these studies and critically appraise them, and then at the end of your systematic review, summarize your just give me a moment. Just summarize your results in the summary. I'll just excuse me for a moment. I'll be back with you. Okay.
This conference will.
So you summarize your results in the end of this this paper or this systematic review. That's a systematic review, and systematic review is not just for the randomized controlled trials. Okay, if I show you this, it's not just for these. They can do systematic review for cohort studies, for case control studies, for cross-section studies, for case series, or even for case reports. So you can systematically review papers of all these types. And some people even mix two types of studies in their systematic review, but let's not make things complicated now. Okay, it's just systematic review is going through the literature and putting a review about the studies which has been done in a certain topic using a specific question. Okay, meta-analysis is involving a statistical analysis of the data about these studies in your systematic review. So just to make it easy, not all systematic reviews has meta-analyses, okay? But all meta-analysis is involved inside a systematic review. Okay, so just a meta-analysis is just the statistical way of putting the data together to reach a conclusion from these studies. Okay, but it's not essential part of systematic review. So when you read a paper, sometimes you said it's a systematic review of that topic, of that question, and sometimes you read something, it's called the systematic review and meta-analysis about this topic. Okay, so not all systematic reviews have meta-analysis, but mostly all the meta-analysis are involved in a systematic review. Okay, so I will go through them again quickly, reading what is written here. Okay, so meta-analysis is a way of combining the data from many different research studies. Meta-analysis is a statistical process that combines findings from individual studies. Okay, we spoke about that. Systematic review is a summary of clinical literature. Systematic review is a critical assessment and evaluation of all research studies that addresses particular clinical issue. The researcher use organized method of locating, assembling, and evaluating a body of literature on particular topic using set of specific criteria. A systematic review typically includes description of finding of collection of research study. Systematic review may also include quantitative pooling of data called meta-analysis, and we spoke about that. randomized control trial. We spoke about randomized control trial. Again, it's a controlled clinical trial that randomly, by chance, assign participants to 2 or more groups. And there are various methods of randomizing study participants in their groups. So we spoke about this randomization. Usually in practice, it happened via computer program or a phone number. You just call and put a code. That's my center code, and they give you the randomization. So you will say this patient will be randomized to this arm, the experimental arm, versus the control arm, or this drug arm versus this drug arm, or surgery arm versus chemotherapy arm, or whatever. So this it's not left to the clinician to randomize it by themselves, okay? And that's called concealment. So the clinician cannot randomize people voluntarily. It has to be done in something away, like a phone call or computer program, and that's what we call concealment. Cohort study, again, is a clinical research study which people who present with a very certain condition or receive particular treatment followed over time and compared with other group of people who is not affected with the condition in the same cohort. Okay, as I told you, in a city, in a certain hospital, in a certain area, whatever, it's a herd or cohort or just group of people followed within time. It's a prospective study. I don't want to confuse you, but there are some retrospective cohorts as well, but that's not our issue. The case control studies, we spoke about case control studies, begin with the outcome, as I told you, because it's usually concerned about the rare conditions or the things that not common to the extent that we can do a cohort study. So start from the outcome and do not follow people over time, and researchers choose people with a particular result cases and interview the groups or check the records, ascertain what different experience they had. So check the records or just ask them, and then compare the normal people with the people who had the pathology. Okay, so it's usually done retrospective. Case control is usually retrospective, and it's called case control because there are 2 groups, a control group, and which is the normal people, and the other group, which the other people who had the pathology. So we have example here. Non-use of bicycle helmet and risk of fatal head injury, a proportional mortality case control study. So studied some people were wearing the helmet and some people without helmets, and just compared what happened. You will never decide to study all people who wear or not wear the helmets and see how many of them will have fatal injuries when they have accident, and how many of them, it's not logical, isn't it? You just start from the end and see how many people had fatal injuries and how many of these group has not fatal injuries. Cross-section studies, as I told you, a certain point of time, the observation defined in a defined population at single point of time, exposure and outcome determined simultaneously. It's just across, definitely, literally a cross-sectional. It's at point of time, you take a cross-sectional in this population to find something. Case report and series, just a report about patients, no control group in this category of of studies, and you still have ideas, editorials, opinion, and these are other types of articles or things that you can read in the journals. Still, of course, there are some animal research studies. So would you invent a new drug, definitely you start testing them in animal, and then you start, as I told you, in studies like this one, just non-randomly assign groups or something of people, just choose a group of people, volunteers usually, and test the drug on them. and there is no control group, just to test the side effects and safety of this drug, or these kind of studies. Okay, that's going through them again and again and again. Before going through them again, do you have any questions? I have to stop here and ask you, do you have any questions, and is everything clear so far?
Yeah, it's clear. Thank you.
Okay, so that's one thing clear. So the rest, everything is clear. It looks like it's clear. Okay, so that's another. Yeah, good. That's another diagram going through it. I don't think we need to go through it. Okay, so now
Excuse me, doctor.
Yeah.
I want to ask about systemic review.
Yeah.
And also cross-section study.
Okay, what's your question?
I want to ask about systemic review.
Yeah, what was the question?
Systemic review.
Yeah, it's a system.
This conference will now be recorded.
What is evidence-based practice? That's the definition of the evidence-based medicine. And to be honest, yeah, don't try to understand it. It's just very complex, basically. Evidence-based medicine, conscientious, explicit, judicious use of current best evidence making decisions about care of individual patient. Just if it came in any exam, and you find conscientious, explicit, judicious, just choose it, okay? In the multiple choice question, if just asking you about the definition of evidence-based medicine. But anyway, just to make things easier, just to understand it, basically, evidence-based medicine is 3 components. Okay, is to incorporate the evidence or the outcome of these studies, okay, the outcome of all these studies into your clinical practice. So there are 3 components, okay, the evidence itself, okay, which are these studies, okay, the research, and the patient, okay, the patient characteristics. And the third component is your experience and your knowledge and everything. So there are 3 components, you have to incorporate them, okay? Using your experience, you have to decide which one of these studies suitable for which patient, because not all these studies can be applied in all patients. Okay, so just incorporating these 3 things, your clinical experience and with the specific patient criteria and the best available evidence for this specific patient. Okay, so you might say in the past there's a clinical problem, you just use your experience and you decide. But now there is a clinical problem, you have to develop a question, an answerable question, and search the evidence and critically appraise the evidence and decide the diagnosis and management. And your critical appraisal, you have to decide if this specific piece of research is suitable for your patient or not. Okay, it has to be suitable for your patient, and you will come at some point now when we discuss the appraising the paper about to speak about the validity of the research. So critically appraising the evidence or the research paper is to look, is it valid internally and valid externally or not. Valid internally means that this piece of research is done in the right way, and valid externally means that this piece of research can be applied to my patient. It can be, taken off this journal paper and applied in clinical practice. Okay, because some people do studies in centers of excellence with a lot of facilities and things. You cannot apply this to your patient. Okay, so that's about thinking about critically appraising this evidence and thinking, is it suitable for your patient or not? And you have to decide and diagnose and use your experience and the patient's specific pathophysiology and deal with this patient. Okay.
Hello, sir. Hello.
Hello. Yeah.
Yeah. How can you?
This conference will now be recorded.
Okay. Levels of evidence. So within all these types of studies, okay, all these things that we've discussed, we need to decide which one of them is stronger and can be used confidently more than the others. Though there are a lot of ways of classifying the evidence according to which one is stronger than the other. There are a lot of ways, and if you are going to do a guidelines or something, you have to decide the specific way you used to classify your evidence. So in this document, you just have 2 ways, but there are a lot, okay? And I found it really confusing to have a lot of ways of classifying this. It is confusing, and I don't have a magic solution for that, okay? So we have to go through it and remember which one of these take which level, okay? But I can make it easier for you, okay, by a certain way. If you started from the bottom, usually the last one is the expert opinion, okay, and usually the one before the last will be the case reports and case series, okay. So if you have a multiple choice question, and you have level 3 and 4 and things like this, and they ask you about case reports, it will be something like 3, okay, because if you started from below above, you will go 4, 3, 2 minus, 2 plus, 2 plus plus, 1 minus, 1 plus, and something like this. Anyway, so if you start from below, it's expert opinion and then non-analytical studies, and then case control and cohort come next. Okay, but here they're classifying the case control and cohort to high risk confounding and bias and low risk of confounding and bias, and these are the enemies of the methodology of any study, is the confounding and bias. And I can tell you what is confounding and what is bias, but not now. Okay, so if you start from below above, you will reach this point. So expert opinion, case reports, case series, and then case control and cohort with high risk of confounding and this low risk of confounding. And then you'll go 2 plus plus, high quality systematic review of these things, of the case cohort and case control and cohort. Okay, I'll stop here. I'll go to the other one. The other one is...
Excuse me, doctor. What is mean by plus 2? What is
This
mean by this?
conference will now be recorded.
Okay, that doesn't mean anything. That's just classifying the strengths of the thing. It doesn't mean anything. It's just classifying how strong this
It is
evidence
mean.
is. Just the way.
What is the strong? It is 4. It is become strong 4.
What do you think? What do you think? What do you think yourself?
4.
No, no, of course. Is the expert opinion stronger than the meta-analysis? No, never. Expert opinion is the weakest evidence ever.
The small
Okay?
number. It is the stronger. It is mean.
No, no, it
What?
is not, and that's why I'm saying that is a stupid way of classifying the evidence, because it is confusing. It is confusing. Okay, so they decided that the number 1 is the strongest. That's their decision. Okay, that's this whatever institution decision. They decided that the 1 plus plus is the strongest. You are right. You are absolutely right. You can decide to start your own classification, okay, and name it by your name, and you say 4 is the strongest for me, okay. And that's why I'm saying this is not, you know, I'm usually not comfortable having these questions in exams, because there are a lot of ways to classify this. There's no consensus, and somebody can, like, you can say, okay, I'll start my classification system and I will decide that the 4 is the strongest, and I will call that the high quality meta-analysis and systematic review of randomized controlled trials with a very low risk of bias, I will call that 4. You can do that, but that's not the reality. The people here and the classification used by the Royal Colleges or the Oxford classification or whatever classification or the NICE classification, not every institute, but most of the institute has its own classification. And sometimes when you read the hospital policies and these things, they have another classification. So it is confusing, I agree with you. But here in this type of classification, we call the 1++ is the strongest. That's what they call it. Okay. And that's why it is confusing, and you have to go through them quickly before your exam if you're going for an exam. But I'm just giving you a way of answering the multiple choice questions if you have to answer this if this came in the multiple choice question. Okay, start from below or start from above. Okay, I'll start from below here because I've started from below there. I'll start from below here. So the weakest here, they call it D. You can say D is bigger than A. So these people are smart. They choose letters, not numbers. Okay, so these people are a little bit smart. So they choose letters and they said, okay, D is evidence level 3 or 4. Oh dear, they came to this one. They choose the 3 and 4 and put it here. Or extrapolated evidence from studies as 2+. It's just not a comfortable way of classifying evidence. I really agree with you. Anyway, C, a body of evidence including studies 2+, directly applicable to the target population and demonstrate an overall consistency of results, or extrapolated evidence from studies related to rated as 2++. These people are just, every study, just not to be confused about extrapolated evidence from studies rated as 2++. So how does that mean? Every study has what we call primary outcome and other outcomes. Okay, so if some people decided to do a systematic review or whatever of the secondary outcomes of these studies, that's not a primary outcome of them. It's not stronger. It's not a strong evidence like the primary outcome. So that might call it extrapolated evidence from studies rated as 2++ or whatever. Okay. And this is how to grade the recommendations or the guidelines. Okay, so these are the lowest things. I'll start from above here. I'm just I want to stop here and tell you there are other ways and numbers and pluses and minuses and even 1A and 1B. There are a lot there. Okay, there are a lot of other ways of classifying evidence, and that's why I found it confusing. But if you've been from below above, it's easy. You can answer your multiple choice question. If you've been from above below, it's easy as well. So 1++ looks like the strongest, isn't it? So this should be the high quality meta-analysis or systematic review of randomized control trials or randomized control trials. Randomized control trial by itself, if it is low risk of bias, can be rated 1++. And just 1+, high quality meta-analysis systematic review of randomized control trial or randomized control trial with a very low risk of bias. It's just the same, isn't it? It's just confusing us basically. 1- is meta-analysis systematic review of randomized control or randomized control with high risk of bias. So that means that the randomized control trials are really strong, and if you decided to do a systematic review of them, it will get it up more and more in the evidence. And that's something subjective. It's not that really objective how biased is this study, how it's not biased. It's not that objective. But anyway, so you have to go through them, and I'm just telling you the easy way in the exam. If you have a question, with a multiple choice question, just go through the numbers of what you have in the choices. Is it 1 plus plus 4, 3, whatever? And I'm telling you, the exam question will come in at the top or at the bottom, basically. They will ask you about the expert opinion, or they will ask you about the high quality thing. It will not come in the middle, because people in real life, they are using this table. So if I'm going to do a guidelines, I will put this table in front of me, and I will do the guidelines, and I would classify them according to what is written here. I will not, try to remember it, basically. Okay, and this is how to do a guideline. You would say this guideline is graded A because it is done using meta-analysis and systematic review and of a randomized controlled trials, or things rated 1++. This is something that the people doing the guidelines just decided before to do the guidelines. Okay, it's not a rigid thing. It is a little bit flexible, and there are a lot of ways of classifying them. I know it's confusing, but you've got the idea. You got the how they do that, how they classify this. Okay, and I'm telling you, there are other ways. To make it very easy, okay, this is a pyramid of evidence. This is a pyramid of evidence. That's what you need to know. And then you look into your multiple choices, and you'll decide which number of them is stronger. You start usually by A is the strongest, or the 1++ is the strongest. You would say, what do you have in the question head? Is it a guideline? It is very strong. It's systematic review. Or meta-analysis, it is very strong. It's probably 1++ or 1+, like this. Is it a very strong RCT? It's usually 1++. Is it a little bit not strong RCT? It is just 1+. Is it a cohort? It's probably 3 or 2+ or 2-. It's a very good cohort. Something, is it a systematic review of cohort? It will be 2. How many pluses? I don't know. It's just confusing, really. Systematic review of case controls, 2+. Okay, so if it's a systematic review of cohort or case control, it's just 2 and 2+. Okay, that's what you need to know, basically. But is it confusing? Yes. Okay, is it not consistent? Yes. Is there other ways of classifying these things? Yes. Okay, but that's what we have, basically. It's usually a confusing question. It's not just not to surprise you, that's not the most confusing part in the session today. Okay, there's still more confusing things, but that's the maximum I can tell you and explain these things to you, because you will never be able to remember these things unless you revise them immediately before your exam, and that's what I did in my exams, or you've been involved in creating guidelines. You have to create guidelines, so you have to remember these things. You remember them just easily, okay? Because people make these things up, basically. Not making them up, just institutions are different in these things. Okay, so but everybody is, happy with this classification and this grading according to the strength. Okay, critical appraisal. So let me stop here and ask you.
This conference will now be recorded.
Okay, so we spoke about the critical appraisal of a systematic review. Critical appraising thing, it's just to, what does it mean, basically? Just to make sure that this piece of research is valid for your practice. And as I told you before, there's something called internal validity and external validity. So internal validity means that this study, the methodology is not biased. So that means that they've done a very good study, okay, with a minimal bias. They've done a very good methodology. They have conducted a brilliant study that with a valid result. Okay, but as I told you before, that doesn't mean that these results can be applied to your patients, and that's what we call the external validity. Okay. And when you look into results, to studies to critically appraise them, you have a look at the results and you have a look: is this result valid internally, externally, or not? And if this study can help me caring for my patients, basically. And that's why they incorporate the research and all these things in the exams and the practice, basically, because most of practice nowadays is done by evidence-based practice. So you have to know if this piece of research or this paper can be applied to your practice or not. Okay. And in order to search the evidence, you have to have this question, as I told you. And if you're going to do a systematic review or to search the evidence for anything, you have to have a clear question, and we call this question the PICO question. I spoke about this before, but I'm just speaking about it now. Okay, so you have to decide which population. Is it women in menopause, for example? So you have to be clear. Not all studies are done in women in menopause. So just women below 18, women between 18 and 25. You will never know. Pregnant women, women in first trimester, women in second trimester, women in third trimester. You don't know. Okay, so you have to decide which population, because this specific pathology might not be, studied in your population or in the patient you want to answer the question for him or for her, basically. Okay, so I have to decide if this paper or this research has been done in a population very similar to your patient. And the intervention, that's your question, is giving chemotherapy then surgery better, or doing surgery then chemotherapy is better? You don't know. Is just giving chemotherapy can solve the problem, or just can surgery can solve the problem? You can create a lot of groups here. Okay, you have, this is the intervention, is what you do. Is this medication can lower the blood pressure? Then is it better than placebo or not? That's the intervention you want to do, and this is a comparison. Okay, and the outcome you are looking for will be in the study. Okay, so I have to know how to formulate your question when you search the evidence or doing a systematic review or whatever. Okay, that's PICO. I don't think I can really explain it more. So that's another example in children with sickle cell disease. Long-term use of prophylactic penicillin absolutely necessary to prevent infection. So that's a question, and that's your PICO. Sickle cell disease in children, that's a patient group or a population or the pathology or whatever. It's PPP, patient population pathology, is the same. Intervention is a prophylactic penicillin, and you compare it with placebo or another intervention, and you will see the outcome. Is it preventing the infection or not? Okay, so that's how to formulate the question, and what does it mean, what this PICO means, basically. Okay. Do I have a question I want to ask you? I think I want to ask you a question. Yeah. So anybody knows what is placebo?
For placebo, it's giving nothing, something similar to the drug, but with no effect.
Okay. So why we do that?
Effect.
Yeah, why we do that?
To be blind study, so no one knows which patient took the drug and which one took the placebo.
Yeah, that's a good thing. Yeah, that's to minimize the bias. That's to minimize what we call observational bias. So if you know, now I'm starting to talk about bias, isn't it? So that's one type of bias. That's what we call the observational bias. So if you know as a patient that you're taking the new nice medication, which is in this specific study, you will you might behave better. You might start eating vegetables and running and doing, you might behave better, or you might be biased in your even feedback if you're filling feedback forms or something like this. So that's some sort of bias. If people knows that they are taking just the new nice medication, this is a bias. And if you are giving somebody nothing, it's not nothing, it's just a sugar tablet, which is very similar to the medication you're testing, they might behave better as well. So you know what I mean? So you are now excluding the observational bias, or what we call performance bias, from your study, because you are giving very similar thing to the two people. They don't know. If you don't know as well, as a doctor, you will be what we call blinded, okay? And the patient doesn't know, so the patient is blinded as well, and that's what we call double blinding. You would say this study is double blinded, okay? Because the patient doesn't know, and you don't know which patient is taking the new fancy medication and which patient is taking just the sugar tablet. Okay, so just excluding here the performance bias and the observational bias. You as a doctor, if you are, biased yourself, and if it is, for example, a blood pressure tablet, and you are taking a measures from these patients, and you want your new drug to be better, or you want to have an exciting result, and instead of recording this patient who's taking the new drug, the systolic blood pressure 101, you just put it 100. You are biased. You are biased toward this new drug. And some people even blind the results to the statisticians. So the one who's doing the statistics is just comparing A versus B, and he doesn't, or she doesn't know which one is the experimental group and which one is the control group. And this is called triple blinding. It's just to blind the statistician. It's just a way of minimizing bias. Okay, the observation, what we call observational bias, or the performance bias, how people perform in the study. Most of the studies are double blinded. Some studies are triple blinded, and some studies you cannot blind patients. If you're comparing chemotherapy versus surgery, how are you going to blind the surgeon or the patient? Because you're comparing medicine versus surgery, so the patient will know that he has surgery. Okay, so it's not always, blinding is not always possible. Okay, but it is a preferable thing, and it's a thing that really very good to minimize bias. Sometimes how we do blinding, so I've seen studies done comparing open surgery versus laparoscopic. Okay, so how are you going to, you will never be able to blind the surgeon, but you can blind the patient. They usually cover the patient abdomen or whatever with a big dressing, so he doesn't or she doesn't know what operation she has. So that's some sort of blinding to minimize the bias. It's just an opportunity came here to speak about placebo and to speak about bias, and at some point I will speak about confounders. Okay, just remember this: the two enemies of any study methodology is the bias and the confounders. We spoke about bias briefly. I think I'll speak about confounders later. Okay, remind me before I finish to speak about the confounders. Okay, moving to the next section. Identifying evidence to inform practice. So you're a clinician now. That's a diagram just for you as a clinician to use in your normal practice. So what do you need to do just to deliver the best the best practice and the best benefit for the patient. So you have to go search the guidelines and evidence summaries. So this is the first thing to do, is to go for the guideline, which is done by the NICE, by your Royal College, by the hospital you're working in. A lot of hospitals in the UK have what we call guidelines or guidance for how to do things and how to deliver the practice about certain things. So that's the first thing you go for, basically. So you will see guideline exists. Okay, appraise and adapt and adopt the guidelines. If there is no guidelines, you'll go for a systematic reviews. And systematic reviews, I think 30% of the systematic reviews available on the internet are in the Cochrane already. You have to know that there is a Cochrane library. There is some people did what they call Cochrane collaboration, and what they're doing in their life is just doing systematic reviews. It's just going through the studies and doing systematic reviews of these studies and giving guidance for the people to follow. You can go to the PubMed or clinical evidence or whatever, just to look for systematic reviews. There are systematic reviews, appraise and adopt. That's it. You just use it. If there is no reviews, you have to go to PubMed or something, or just PubMed is one of the most famous websites you can look for research, PubMed or MPass or whatever. Just look for papers suitable and then use this paper according, you will weigh this paper according to this pyramid. How strong is this paper? And you have to critically appraise this paper and see, is it suitable for your patient or not? Okay, that's how you apply what we have discussed in your practice. So you go for the guidelines, and then you go for systematic reviews, and then you go for the literature, PubMed and these things, and then you have to speak to expert if there is nothing in literature, which is really rare. There are millions of papers around, but anyway, sometimes you have a very unique problem with a very rare patient, so you have to speak to an expert or just and in this occasions, by the way, you have to think about this rare occasion or this rare pathology is just to publish it yourself as a case report, because you have to participate in this thing. You have to help other people as other people helping you with millions of papers. Okay, so that's the other section, critically appraising randomized control trial, how to critically appraise the randomized control trial. I think we spoke about this briefly before. The study selected for systematic review needs to be assessed in their quality. There are numerous quality checks in the randomized control trials. First thing, are these patients randomized and how they are randomized? We spoke about this. Usually it's the randomization should be concealed. So some people, for example, can say, okay, this patient looks that he will follow the instructions. So shall I randomize him to the experimental group if I'm broad experimental group? So randomization should be concealed and you shouldn't have any control in the randomization yourself. It should be away from you. Should be something like a phone call to a computer to give you the randomization code or whatever. It should be complex. It shouldn't be like a coin toss or something like this. It shouldn't be in your control at all, because you might be biased. And you need to make sure that the groups treated equally, and that's why we blind people, we blind the patient, we blind health worker, and the patient analyze group which is randomized, and the follow-up and these things. It's just the same thing we spoke about, really. Is nothing out of we haven't discussed. So there are some biases here: selection bias, and that's why we randomize people; performance bias, and that's why we blind people and we blind doctors; measurement bias, and that's why we blind the outcome from the statistician. So that's and from the clinicians. That's how we minimize the bias, and that's how we critically appraise some papers. Okay, what we did to minimize this bias, basically. Okay, is everything
This conference will now be recorded.
okay? Just to start again, for clinical questions about the effects of therapies and interventions, systematic reviews of randomized controlled trials can provide the highest level of evidence. Yes, I know that. We know that, aren't we? Randomized controlled trials are the most vigorous way of determining whether cause-effect relation exists between treatment and outcome, and assessing the cost-effectiveness of treatment. Yes, we know that now, aren't we? Loss to follow-up. Yes, these are some definitions, isn't it? So loss to follow-up is a number of patients who completed the trial in the control and treatment group. So there's something else in these randomized control trials. You might start the trial with, I'll just give an example really. 1,000 patient in the control group and 1,000 patient randomized group, and then by the end of your trial, there are some people they have lost the follow-up. And these people can be people in the treatment group or from the control group, and you will never know why they have lost the follow-up. There are some questions raised about people lost follow-up. You might have lost the interest. They might just traveled and died. You will never know. Okay. And when you do your analysis, and just maybe by the end of the study, you have now 900 in your experimental group and 950 in the control group. So if you are, doing your statistical analysis and your statistics, and you found that, for example, 100 have a brilliant result in the experimental group, and about 90 had a good result in the control group. So when you do your statistics, you find that you're comparing 100 out of 900 in the experimental group, and 90 out of 950 in the control group. That's not fair, isn't it? So because a lot of people have been missed in the experimental group, and you don't know why they have been missed. They might have died from this treatment. Okay, so you don't know that, and that's something in the research or in the randomized controlled bias called attrition bias. Okay, it's called attrition bias. So when you miss people, or people miss follow-up, and there are some statistical ways to adjust for this attrition bias. Okay, so that's another way of bias I'm just telling you about. Okay, and you can, in your statistical analysis, adjust for it just in your statistical analysis, really. So that's loss to follow-up. Meta-analysis is an important method to summarize the results of different studies by employing statistical methods. We know that. We've been through these things. There are different levels of evidence. We know that depending on type of research, critical appraisal of systematic review should be assessed for possible bias and methodological flaw. Where, by time we're discussing and exploring these biases and these methodological flaws. Okay, if I give you a list of biases and you've been through them, it will be confusing and you will forget them. Okay, I'm just giving you examples while we're going through these things. High quality systematic reviews with homogeneity of results provide the best source of evidence for evidence-based medicine. So these statements, all these things are, you know, things that can come in multiple choice question. So what we call forest plots. Forest plots is something can be asked in the multiple choice questions, and even in Viva questions, and in research you have to be familiar with forest plots. Forest plots is when you're doing a meta-analysis in systematic review. Okay, you have some studies, you have to put their results in a graph. Okay, so now you're doing systematic review, meta-analysis in a systematic review. So you have some studies with results, whatever these results, survival, or what we call life, disease-free survival in cancer and these things. So we measure how long the people who had cancers, for example, survived after this treatment, or how long these people survived without recurrence after this type of treatment. So we call this survival, or we call this disease-free survival. And we have a lot of studies comparing, for example, chemotherapy versus surgery. Okay, and these studies have the number, so the median survival after chemotherapy is 5 years, for example, and the median survival after surgery is 6 years. I'm pro surgery, so I'll say 6 years. And we have what we call confidence interval. So what's confidence interval? So how much are we confident about the 5-year number, and how much are we confident about this 6-year number? Okay, and these 95%, this confidence interval is done statistically. I'm not in a position now to describe how it's been done, but it means that we are 95% confident that the survival after this type of treatment will be between 5 to 6 years, with a median of 5 years after chemotherapy, or in the surgery it will be 5 to 7 years with a median of 6 years. And that's how we are confident. We are confident 95% that chemotherapy will give you survival between 5 to 6 years with a median of, I've just mixed the numbers up, isn't it? So 95% confident that it will give you survival between 5 and 6 years with a median of 5 in chemotherapy, and 95% confident it will give you 5 to 7 years with a median of 6 in surgery. And I will show you now the graph with other examples to just explain it more. But I'm just giving you, an conceptual idea about these things, how the forest plot done. So there will be studies giving this result, and there will be other studies saying that no, chemotherapy does better. It does give median survival of 7 years, and we are confident 95% that the survival will be between 6 and 8 years with a median of 7 years. Okay, so there's another study, that's another study, but the surgery will give survival of 6 years with a 95% confidence it is between 5 and 7. Okay, that's another study. So these are two studies comparing chemotherapy to surgery with two different numbers, and one of them is saying that the chemotherapy is better, and the other one is saying that the surgery is better. I will leave that, you know, to I'll leave you to absorb that for a minute now. Just give me a minute. Back.
This conference will now be recorded.
So this might be confusing, but if I scroll down here, it might be less confusing. Okay, imagine that this is a study. I said that, so that's probably that's a surgery here. If people had surgery, or people had chemotherapy, whatever, that's favor treatment, that's favor surgery, and that's favor control, the chemotherapy. So that's study, and this one is access, this is survival, how far away this study is pushed away from the death of the patient or whatever. This study said it's from 4 to 6, and the middle is 5. And this and another study said the opposite. It favors the control, favors the chemotherapy. And that's how we plot all the studies on this axis. I'll go through it again with this example. So how to do the first plot. So name on the left, and squares are relative risk or odds ratio of the individuals, whatever. Square size is the weight of the study. So I have to weigh the study, how strong is this study, and how many patients was this in this study. So the bigger the square, the stronger the study. Okay, and the 95 confidence interval, that's the horizontal line. That's the horizontal line. Okay, that explain how much I'm confident that my result or this study result is right. And I will never be 100% sure. I will probably, we've decided in medicine, it's enough to be 95% sure. Okay, so that's a number. It's just been decided or agreed upon by the medicine people. Okay, that's not a fixed number. Some people might say, I will decide to choose 99%, but I will not confuse you. In medicine, it's 95, and it will be always 95 for some time. Okay, it's 95 confidence interval. So when you describe an outcome from a study, it has to be 95% confidence between this number and that number, and this is what this line indicate the 95% confidence interval. And this vertical line, the line of no effect. So some study might show that the chemotherapy is exactly like surgery. So we'll find the square here, and you'll find the 95% confidence interval line here as well. But you'll find this square exactly at this line. There's no effect of the surgery versus chemotherapy. This one, surgery is better. This one, chemotherapy is better. But the 95% confidence interval, they're overlapping. The surgery and chemotherapy are overlapping at some point in this study. So it's touching the this axis. And I will let you know, I will give you an example how they are overlapping. This study might, I'll give you numbers, okay? Just to confuse, I'm not trying to confuse you, but just to give you an idea. For example, if I said the chemotherapy can give you survival between 5 and 8 years. So it's 5 and 8 years. Okay, it will give you, I'm confident 95% that the chemotherapy will give you a survival between 5 and 8 years from this study. And from the same study, they said that the surgery will give you a survival between 3 and 5 years, 3 and 6 years. Okay, so if you imagine that there are some overlap between these two results, 5 to 8 and 3 to 6. So they are overlapping. Okay, so you cannot say confidently that surgery is better, chemotherapy is better than surgery. They are overlapping. These periods are overlapping. okay? And in this occasion, you'll find your study touching this line, this vertical line. This study will not be that significant, okay? It will not be statistically that significant. You still weigh it, you give it a weight in your meta-analysis, but it's not that significant. The significant study is not touching this line. There is no overlap between the two groups, okay? So the vertical line of no effect, and which one of these is touching the 95% confidence interval is touching this line, and which one is not touching. If a study is touching this line, there is an overlap, and this study is not that significant, okay? If the study is not touching the line, and it's away to one side, and the square is bigger, as you can see here, it is strongly significant, and it is weighed more, and it is, you know, it will shift the conclusion, which is this diamond here, to this side more. That's the conclusion. I will come to it later. Yes, diamond is the overall treatment. When you do this statistical analysis of all these studies, you will reach this diamond, and you will see where is this diamond from the conclusion of all these studies statistically. You'll find that it's visually, you can see that it is more towards this side. So it's probably this diamond will be in this side, okay? And the width of this diamond, this width is a 95% confidence interval of the all collective data statistically. So you don't have here a horizontal line. You just have the width of the diamond is represent the 95% confidence interval of the collection of this meta-analysis. I'm not sure if it is confusing or not. It's confusing a little bit, isn't it? Okay. Do you have questions now? Let's stop here and just explore what you absorbed and what you didn't absorb. Okay. Questions? No questions.
So
No,
can we explain what's so the first plot is the whole thing, the whole,
yeah,
the 5 or 6 whatever
yes.
studies
Yes.
we're comparing,
Yes.
and then at the end
Yes.
the confidence interval, right?
Yes, exactly.
why
So
it
these
is why it is named forest plot?
I don't know. Maybe the guy who just did it. I don't know. I don't know.
Okay. And how to say that this is significant or not? Or this is coming.
Yes,
Yeah.
if something touching this line is not significant, so the conclusion is not touching the line, isn't it? So that's a
Okay.
significant result. Okay, so this is the 95% confidence interval. If it is touching the line, so probably these two types of treatments are overlapping in their periods, and that's why it touched the line. Okay, so that's the chemotherapy, for example, and that's surgery. So that there is some sort of overlap between both.
Okay, so the vertical line is the line saying that it's insignificant, or this part is insignificant, which
It's a
touched the
balanced
line.
line. Yes, if you imagine, yes, if you imagine that's a scale, it's the middle line. That's
okay, and the square on the horizontal line, it doesn't move right or left. It's always in the middle.
Yeah, because that's the weight of the study. It just represents the weight of the study. How big is it? Is how big the weight of this study? And you can see that the weight of study affects the 95% confidence interval. That's another thing. If your study has a lot of people, you will be more confident about your answer, and that's why it's tight here. Okay, the numbers will be tight. If you have a small number and the weight of the study is light, you will be not sure. So the 95% will be longer.
The diamond, the diamond shape, or the diamond center, it is always present in meta-analysis.
Yes, it's that's the question. If any question has the word always, I will answer no. but most of the time, yes. There are the first plots used in other things other than meta-analysis, to be honest, okay? But for you now, it's just for meta-analysis, okay? You can use it for other things, okay? But for you, for exam purposes or for other things in general, it's been created and done and basically used in meta-analysis. Okay, and you can reach a diamond at the end. You should reach a diamond at the end to give you a conclusion. Okay, can it be used in other things? Yes, it can, but it is, I would say, yes, it's always used in meta-analysis, but not exclusive for meta-analysis. Okay.
How the diamond expresses its conclusion?
So after doing the statistical analysis about all these, you can, the statistician or the researchers or whatever, they will reach the number, so they can draw this diamond. This is the end point of their statistical analysis. Okay.
If it is statistically not significant, and all the horizontal line in this meta-analysis touch this vertical line.
Yeah. So we need more studies. We need to do more work on this issue. It's not significant.
The question not come in this way.
I don't know. It can happen. It can happen. We can just prove that this treatment is not better than this treatment. It can happen.
Yeah,
why not?
So in this way, in this situation, don't this drawn diamond, right?
This conference will now be recorded.
Yes.
Sorry. Dr. Mohammed, can you please show one more example? For example, when I study, I have seen people using metformin, without metformin, like that. Like that, some example, if you show us, I think we will have a better idea. Is it possible?
Okay. Yeah. Well, just give me a link or give me something I can show you. I will show something. Okay. I will say it again.
This conference will now be recorded.
So, in doing a study, we're not testing the whole population. We are not doing a cohort study to the population of the Earth. Okay. So just usually select a sample. When you select a sample, there is a chance that your result will be wrong because you have not selected the right sample of people, or by chance, by statistics, by nature. Okay, you might have selected the sample that give you the wrong result. So we have to use some what we call statistical tests to just give an idea how far we are sure that our results are right. And the statistical tests give numbers. I've decided that if this number is related to type 1 error. Type 1 error is this one, and it's about how strong are we confident that we are rejecting the null hypothesis. Null hypothesis is there is no difference between, for example, the treatment group and the control group. Okay, so if there is no difference and we've rejected it, that's wrong. That we've conducted a wrong study. And the p-value is calculating how far we are wrong. If we can be wrong less than 5%, that's statistically significant. That's okay. That's accepted in medicine. Okay. In other fields of science, they have other numbers. Okay, but in medicine, it's okay to have a p-value less than 5%. We would say that's a statistically significant result. We can reject the null hypothesis confidently. Okay, and the type 1 error is a chance of having the null hypothesis true. So you are wrong. You are doing a wrong thing. If you are doing a wrong thing by chance of less than 5%, that's accepted. So you're doing the right thing 95% because we're just selecting samples of people. We're not doing the studies in the whole population. Do you get this point? You'll forget it in 5 minutes, but anyway, that's the meaning and why we have a statistical test and we have what we call type 1 error and we have what we call type 2 error. Type 2 error is the opposite, but it's less wrong than the type 1 error, and that's why most of the people are just concerned about the p-value and how we calculate the p-value. Okay, there's another way of doing it. One of the philosophers did that. I don't know how many 100 years ago. So it just this is you know, are you going to believe in God? Do you not believe in God? So if the God exists and you rejected God, that's a big mistake. But if the God doesn't exist and you accepted God, that's a minor mistake. Okay, and you have the other thing. And if the God exists and you accept God, that's a big payoff. Okay, so that's another way of showing how the type 1 error, we are usually concerned about type 1 errors because it is something done in the recent, I think the last decade or something. They just invented this null hypothesis. We have to assume that we have a wrong conclusion or a wrong answer until proved otherwise, and I have to calculate how wrong we are. And if we are wrong less than 5%, that's a statistically significant answer. So we are right. We are possibly right because we are right more than 95%. Is that okay? It is confusing, but that's the idea behind it. Okay? Is it clear? If you said it's clear, I will not believe you, but anyway. And that's why we have this table. Have you seen this table before, or this graph, or this diagram, or this flow chart?
Dr. Muhammad, I believe that
This conference will now be recorded.
Again, so there are some statistical tests. Before going to the statistical test, I will differentiate between the clinical significance and the statistical significance. As I've spoke already about statistical significance is p-value less than 5%. Okay, it's a p-value. If something has a p-value less than 5%, that's statistically significant. But it's not always clinically significant, okay? Because you might have a treatment cost $1 million a week, and a treatment that causes $100 a week, and they give very similar results, okay? But there is some statistical significance in these outcomes of the results, but they're not really that relevant clinically. So you would say it's not clinical significant, it's not financially significant as well. So although it is statistically significant, it is not that clinically significant. It doesn't make any difference if somebody has a blood pressure of 115 and somebody has a blood pressure of 120. Although this treatment makes it 115 and this treatment makes it 120 with a statistical significance, but for me as a clinician, it doesn't make a lot of difference, okay? And the opposite is right. I can have a study with a statistical significance p-value more than 5%, okay? So it's not statistically significant, okay? But the treatment make a big clinical difference, okay? So they're not the same, but they're not usually goes together, but they're not the same, okay? So something might not be statistically significant, but I might still use it. It doesn't mean that, you know, if something is not statistically significant, don't use it. No, you can still use it because it has clinical significance, okay? Is that point clear? Because sometimes it's not clear. They're not the same, the clinical and the statistical significance. They're not the same, but they usually goes together. Okay. To this flow chart. So just to start explaining this flow chart, before my exam, I kept this photo in my mobile just to have a look at it before I went to the computer to start my exam, okay? Because it's very, very difficult to decide which statistical test is, to remember them basically, which statistical test is suitable for this type of study, okay? Unless you have done some statistics, statistics course, or you've done a lot of studies and you've done a lot of statistical analysis, you will not remember them. Okay, it's not easy. Okay, it is confusing, and my solution to it myself is I kept this photo on my mobile and had a look at it before I started my exam. Okay, and fortunately I had a theme, a full theme, just full of these statistical tests, and I assume I've done it, and I've done them right because I've passed, so I think I've done them right. But anyway, so just keep this image with you in your mobile and have a look at it before you start your exam. Okay, just these are the statistical tests that give you, by the end of a statistical analysis, a number which is a p-value, okay, to say how much or how far you are wrong about doing a type 1 error of these studies, because as I told you, we're just selecting samples. We are not doing the study in the whole population. Okay, so these are the statistical tests done by statisticians, so they have names and stuff in them. And you have just to choose the right statistical test for the right type of the data, basically. Okay, I think instead of going through this flow chart, I will go through the questions, and then we'll go through the flow chart and see which one is suitable. Okay, so the important thing is the outcome data of your study. Is your outcome data continuous or categorical or survival? That's really a key. Okay, so if your outcome, if the outcome of your study continuous, what do you mean by continuous? Just to make things very easy, continuous means numbers. Okay, continuous means numbers. If the outcome of your studies is, numbers, you just go through this purple thing. If the outcome of your study categorical, just for example, severity of pain, grade of tumor, grade of something, it will be categorical. If the outcome of your study is survival, okay, it will be survival, and that's easy. If you are, so let's finish this now. We can finish this now. If you're doing survival analysis, if you have a study and in the exam they ask you that we're doing survival analysis, is usually what we call Kaplan-Meier plot. Kaplan-Meier plot is like a staircase, like steps. If you just Googled Kaplan-Meier plots, you'll have a lot of Kaplan-Meier plots in Google. Okay, so Kaplan-Meier plots are the survival analysis things. Okay, so if you have a question in survival, it's Kaplan-Meier plot. Okay, if you have other things, let's go through them one by one, just by questions. Okay, to compare the mean time of delivery between ventouse and forceps delivery. So you're comparing time to time. You are comparing number to number in two groups. Okay, so it's numbers, so it's continuous. So we'll go up, so it's continuous, and two groups, so probably it will be two sample t-test. We'll go to the answer, it's two sample t-test. Okay, let's read what they put here. The correct answer to sample t-test, the independent Amber t-test, ideally suited for situation. It doesn't make sense, all these things, but it just makes it easy for you. If there are numbers, go for continuous and see how many groups. Okay, and one group, two group, paired. Paired means that you measure thing in the same group of people twice. Okay, just for example, without the blood pressure tablet, we measure the blood pressure, and then in the same group of people, you give the blood pressure tablet and you measure the blood pressure. So comparing number to number in the same group of people, so that's paired. Okay, two groups or something like this. Okay, let's go for the next one. To compare the decision delivery time interval in the second stage for forceps, ventouse, and cesarean. So it's a time, so it's continuous, and we have one group, two groups, three groups. Let's go here. Three groups. It should be ANOVA test. ANOVA is I will tell you another problem that they have different names as well. So the one test have a different name, but that's easy. ANOVA is analysis of variance. So that's analysis of variance. So go here to the answer. So the answer is analysis of variance. Okay. So again, to assess whether hemoglobin A1C level is related to birth weight. So this is number and this is number. So comparing two numbers. Go here, up, number and number. So it will be correlation. Number to number, there are usually curves or lines, so it will be correlation or regression. So when you have a look at the answers here, you'll find this Pearson correlation test. So numbers to numbers are correlations. Number to numbers are correlation. And the other problem I told you about is they have other names, which is, confusing. But anyway, okay, to determine whether age parity smoking affect birth weight. So these are categories affecting numbers. Age parity smoking categories affecting numbers. Do you have categories affecting numbers? Categories affecting numbers. So it will be logistic regression. Okay, it will be here. You have to just do it like this. What are the things that are affecting and what you are measuring? Okay, so the outcomes and the other things basically. Whether forceps delivery increase chance of having pelvic floor surgery later. Oh, so it's forceps delivery or not, and having pelvic floor surgery or not later in life. Is it category to category? Probably. Category to category. It's just confusing anyway. A category to category is chi-squared. Let's go and see it. Category to other groups. It will be yes or no. If it is more, there are two groups, having surgery or not. So it will be chi-squared. So forceps delivery or not, having surgery or not, two things and two groups, it will be chi-squared test. Okay, so it's outcomes. Is it numbers? Is it categories? I'm just trying to make it so easy. Okay, are we comparing? Do you have groups measuring numbers, or we have numbers related to numbers, or groups? Just going through this will makes it easy for you. Again, to compare weight loss, that's a number, isn't it? In women before and after attending healthy eating program. So that's a number, and it's going through categories. So weight loss, continuous. and attending or not attending. Is it two simple t-test? Let's have a look. Yes, it's t-test. Okay, so it's a t-test. So I have to see the outcomes. Okay, it is confusing, I know. You have to do it in a lot of questions, okay, and go through this. I don't promise you that you will remember this easily unless you've done a statistical course or something like this. But these are the tests that are invented to calculate the p-value for these types of studies. So you have to go through them to go through them like this, just to try to make it so easy. Are the outcomes numbers in groups or groups in numbers, categorical and versus, versus continuous, and survival? We know it's a Kaplan-Meier plot.